everyone, welcome back to our second part for Chapter 6. As a reminder, this chapter is entitled Bones and Skeletal Tissue. In the first part of our session, we ended up by taking a look at a comparison between compact and spongy bone. And I want to kind of finish off that conversation by comparing the laminar bone setup or the ostean setup of a compact bone versus the more trabecular setup of a spongy bone. So let's go ahead and take a look at the image that we're seeing on our PowerPoint. And what we're looking at is the fact that compact bone is composed of osteans. And an ostean is basically the structure where you have a central canal in the middle that will house all the blood vessels. So you can see your arteries and veins pictured here in red and blue. And then you will also have the nerves here, which is the greenish string that you see protruding out on the side. Surrounding the central canal, you will have what we call lamellas. And around this lamellas, or I should say embedded within the lamellas, you will find the lacunae, or the little cavities that the osteoblast will form, and eventually they'll come trapped in, allowing the name of the cell to change from osteoblast to osteocyte. Now, nutrients will diffuse from the central canal down the lamella through these pathways or little channels called canaliculus. And these will then allow the nutrients to connect every single part of the ostean, and of course for the waste products also to be diffused back over to the central canal for disposal. Here is another image of the compact bone, and I think that most of us, when we think about the histology of the compact bone, have seen something very similar to this image right here, where you can see the entire ostean, and you have the central canal in the middle. And then notice how they went ahead and they labeled for you the lacunae with the osteocytes. Those are the darkened little lines that you see all over the place. And of course, here is another view of it. I particularly like this image of it because it highlights the canaliculus, the little canals that will connect one lamella to another, allowing every single part to have access to nutrients and be able to do waste disposal. And then the larger picture on top shows you how it's all put together. So you can see the laminar setup of it, very organized method of not only the cells, but also the blood flow distribution and access to the nerves. Now, when it comes to spongy bone, one of the main differences is that you won't see any osteans present. And part of that is because the organization of the spongy bone is a lot less stringent, as we saw with our compact bone. Instead, what's going to end up happening is that you will have these like little cables that we refer to as trabecula in the first part. They will go ahead and they will form or be organized along the lines of what they call stress. So the amount of tension or the type of tension that's being placed on along with the bones. There will be still access to blood supply, and this will be happening within the cavities of the trabecula itself, because there is no central canal. In fact, I like this picture right here because what it does, let me just go ahead and erase my previous marking right over here. Here's a little insertion of the epiphysis, the end part of a femur bone. And as you can see with the spongy bone, you'll have the small little cavities. And what it's trying to highlight here in purple and in red is that the trabecula, the lines, if we look ever so closely, they will align and form along the lines of stress being placed on the bone. So even though it doesn't have an ostean, it still has a very important method of maintaining its strength and resilience by getting the trabecula to grow along lines of stress. All right, now the process of ossification is basically when we take a look at the entire entity of how bone tissue is actually formed. And this will start around month 2 of development, and it will continue on until early adulthood. And once we reach into adulthood, even though we don't grow lengthwise anymore, we do rely on bone remodeling and repair because, as we discussed in part 1, bone is considered an example of an organ. Excuse me. And it requires a lifetime of a balance between osteoblast and osteoclast activity to maintain the overall thickness and strength of the bone. So the question then is, well, then how exactly do we do the ossification? How exactly do we form the bony skeleton? And what we see happening is that we have two options, or we see two methods. The one that is preferred is called endochondral ossification. And in endochondral ossification, and I'm going to show you an image of it in just a second, what we see is that the hyaline cartilage, which was our starting point for the skeleton, is slowly replaced by the bones. And the bones are then often called cartilage bones just because of their origin point. Now, once again, I want to reiterate that the cartilage doesn't become bone. The bone is going to go ahead and infiltrate the cartilage and then completely replace it. And endochondral ossification is what we see for most of our skeleton. Then we have another process which I find extremely interesting. It's called intramembranous ossification. And we see that the bone now, instead of being completely replacing the hyaline cartilage, we see that it actually starts to develop within the fibrous membrane. And that is then why it's called a membrane bone. The intramembranous ossification process, which I will also show you an image of coming soon, this one we only see in certain bones of the body. So at the bottom of the PowerPoint, you might see the statement. It says it entails the flat bones of the face, most of the cranial bones, and then a good deal of the clavicle. Not the entire clavicle, but a good deal of the clavicle. All right, so let's take a look at the endochondral ossification, where the bone forms and just completely replaces the cartilage. Here we go. We have 5 main steps that we see happening. And notice how on top it highlights the fact that it will start around month 2, and it will continue on from childhood into adolescence. And then once you get into adolescence, remember that you're then all about maintenance, not exactly growth or elongation of the bone. So starting off, you could see that your initial format will be of hyaline cartilage, and the hyaline cartilage will see the formation of a bone collar that will form around the diaphysis or the shaft, and it will allow for a small cavity to form that will be entitled the primary ossification center. This ossification center, we see that that area starts to deteriorate the cartilage, allowing for a larger matrix to open up. And as this is happening, the cavity starts to develop, which then allows for what we call the periosteal bud to invade within the cavity. And as you can see, this is aided by the blood vessel that the bud brings with it. So you can see the blood vessels start to infiltrate into the matrix. And what we see happening is that spongy bone then starts to form. As this is occurring, then we see that the spongy bone will start elongating. And right here in step number 4, it tells you that the diaphysis will elongate and the medullary cavity will start continuing to hollowing out until, or I should say the cavity will continue to hollow out until we can start entitling it as the medullary cavity that we've previously seen in our other bone images. In order to assist the process of the bone replacement, we also see that secondary ossification centers will open up, which will allow access to the epiphyseal blood vessels. And as these blood vessels enter into the center, we see that additional spongy bone is formed. And over time, as we get to our final step, we see that the epiphyses start to ossify, which means that they start to harden as the bone comes near its end of formation. And the hyaline cartilage is basically completely replaced by the bone, except, of course, by the epiphyseal plate and by the articular cartilages at the end. Those will remain intact because of their different functions. Epiphyseal plate, of course, is our origin site of new growth, and the articular cartilage is around the epiphysis or the end parts that help with friction and joint connection. Now, so this is the endochondral ossification. As you can see, we started with the hyaline cartilage on the left, and by the time we got to the right, we see that the cartilage has been replaced by spongy bone and, of course, also compact bone, leaving only a few areas of hyaline cartilage. So this is endochondral ossification. This is what most of our skeletal system will do. And I did say another way, the intramembranous ossification. And in the intramembranous ossification, what we see happening is that it's going to occur within the fibrous connective tissue membrane. So you will have some mesangial cell that will be clumped together, and what we see happen is that they will differentiate into an osteoblast cell. And these osteoblast cells will then become the ossification center, which in essence is our first area or site of trabecula that will start to form. Now keep in mind this is happening within the membrane, so it's intramembranous ossification. Oh, excuse me 1 second, we'll get rid of that. The next thing is what we see happen is that an osteoid is secreted within the fibrous membrane, and the osteoid is basically a form of an extracellular matrix, and these are secreted by the osteoblast cells, and that will start to calcify and harden. Now, keep in mind, just as what we've discussed before with our chondrocytes, as the osteoblasts build the osteoid, the extracellular matrix, they will eventually get trapped within their little lacunae, and then at that point we see that they become osteocytes. As the osteoid expands, and we can see that the collar of osteoblast cells will start to form, we then start seeing that the embryonic blood vessels will come and assist with the osteo process, and that will then ultimately result in a network of more trabecula that eventually will become very compact so that we can refer to it as woven bone. And this is all assisted by the vascularization or the introduction of the blood vessels in this particular region. We start seeing the laying works of the periosteum by some mesenchyme cells that will condense around, allowing for the membrane to form. And as we get to our final step, we could see that the laminar bone, aka the compact bone, will then replace the woven bone. And of course, we could start seeing some of the main components, such as the fact of the formation of the periosteum that has formed itself. And you will also have some trabecula left over, and of course this will help lay our spongy bone or the diplo, allowing for, once again, the complete bone formation to occur. And the origin of this, once again, was within the membrane of the tissue. So this is called intramembranous ossification. Such an interesting process. So after we do our postnatal bone growth formation, then what we see happening is that these bones will continue to grow lengthwise. And then, of course, bones will also be able to thicken through appositional growth. Appositional growth was discussed in part number 1, where we talked about the fact that the cells will grow from the surface, from the extracellular matrix outwards. Bones will stop growing during adolescence. And then at that point, it's all about maintenance. Although there are some facial bones, I did like the statement, that will continue to grow during our lifetime. As we're looking at the interstitial growth, so the internal growth of a bone, keep in mind that it requires the starting point of the epiphyseal plate initially, and that is, of course, where you'll have your cartilage. And as the cartilage grows, it was then eventually will be replaced by bone. Within that epiphyseal plate, we do see that there are 5 zones of growth, starting with the resting zone, proliferation zone, hypertrophic zone, calcification zone, and ossification zone. And I think it's best if we take a look at an image so we can see what's happening. So here is our epiphysis, and as you can see, we have our epiphyseal plate. And when we zoom in, what we see is that we have 5 distinctive areas, starting off with the proliferation zone. To proliferate means to multiply. So that is where our cartilage cells are undergoing mitosis and increasing in cell numbers. And as you then migrate downward, you start to see that now they become enlarged. And that is because that's called the hypertrophic zone. The older cartilage cells will become enlarged, and you can see they have their lacunae that'll start surrounding them. Now at this point, what we see happening is then we're going to go ahead and need the matrix to start calcifying. So we have the calcification zone. And at this point, because of the calcification of the matrix, we do see that the cartilage cell starts to die off and the matrix starts to break off. But that's okay, because blood vessels are also invading the cavity, which are bringing over osteoblast cells, which can then start initiating the deposit of the bone matrix. And that, of course, will then lead us to the new bone formation site, which is the ossification zone within the epiphyseal plate. As you near the end of your growth period, what we see happening is that the epiphyseal plate will start narrowing, and eventually it will close down, and it will leave a remnant of it, and that is then called the epiphyseal line. All right, so here is actually what I just mentioned. It's that near the end of adolescence, the chondroblast will divide less often, which means the plate will thin, and then we have basically the remnants, which is the epiphyseal line. It happens for different ages. So as we can see, I should say it happens differently for the sexes. Part of this has to do with our differences in hormonal levels, like estrogen versus testosterone. Females usually see the peak of their growth and the termination of it around 18 years old. Males tend to grow a little bit longer and see the usual closing of the plate around 21 years old. There's been lots of research done that shows that the epiphyseal plate will respond to hormonal controls. We see that the spike of growth hormone from the anterior pituitary gland and an increase in testosterone and estrogen, marking the beginning of puberty, usually also stimulates a increase in growth within the epiphyseal plate. There's also been studies that have shown that if you have patients that are in puberty and they go on growth hormones, or I should say that they start taking steroids or artificial testosterone, it can actually speed up the closing of the epiphyseal plate, allowing for a shorter stature to be the end result of that particular consequence. All right, now the bone will also be able to grow widthwise. So and this will continue basically throughout our lifetime as the bone is maintained and exposed to different tensions and stress points. So here in the middle of the slide, it says the bones will thicken in response to increased stress from the muscle activity as well as added weight. And I always like to tell my students, well, imagine that we were to go and take x-rays of your forearms. What we would see is that your dominant arm would be slightly thicker in the bone width than your non-dominant hand. And part of that is because of the additional stress and usage that you place on it. And now what if one day you say, you know what, I'm not going to be utilizing my primary hand anymore. I'm going to switch it up. Well, when you switch from left to right or right to left, what we see happening is over time, you will see a thinning out or a narrowing of the non-dominant hand and a thickening of your new dominant hand. And that is because the bone is a living organ, so it is continuously changing and adapting to the pressures and the stresses that you are placed upon it. So the slide also reminds you that your osteoblast cells, your bone building cells, can be found both on the periosteum, and it will allow it to secrete bone on the matrix of the bone. And then you also have osteoclasts, which are the bone breaking ones. They tend to remove the bone on the endosteum surface. And once again, this is all working on the thickening of the bone, not the elongation. So here's just an example of how we can have bone remodeling. And as you can see, starting from the left to the right, the overall shape of the bone will slightly change. And part of that will be based on the pressure that is being placed on it. I think a really good example of bone remodeling is when we take a look at braces. So when a patient comes in and they determine that they don't like the way the teeth are growing, or there's not enough space, or the teeth aren't straight enough, they'll go ahead and they'll get braces done. And what the braces do is they apply pressure on the bone, on your jaw, indirectly. And as the pressure is being placed on it, we see that the osteoclast cells will start very slowly breaking down the little alveoli pockets of bones that hold the teeth, and it will then build the trabecula, and it will build the bone in the lines of stress. And as they build it according to the lines of stress, the teeth move along with them, allowing you then to straighten your teeth or better organize your teeth. So that's in essence a good example of how your bones are continuously remodeling and replying to the stress. This is also one of the reasons why people who have braces will often have to go in and they'll have to get it tightened or loosened. So it all depends on how the growth is occurring. And it's the same kind of thought process around those of us who don't do braces, but like to do Invisalign. Invisalign is also adding pressure to the jaw and the alveoli processes, the bones over there that hold the teeth, and the cells then respond to the stress by breaking down and then regrowing to strengthen the lines and help best with the stress being placed upon them. All right, so when you do your bone remodeling, as I said, it's a breakdown and a buildup. So what we see is we kind of call that bone deposit and bone resorption. And it basically entails a balancing act between your osteoblast and your osteoclast cell. And it can happen on both surfaces, so both external and internal onto the cell. And as a reminder, remember that when you're doing your bone building or your bone deposit, we see that as that bone matrix starts to be formed, initially we see by our osteoblasts out that is referred to as an osteoid seam, which is kind of like the mark of unmineralized bone matrix and the border end of the new matrix. And then you'll have a calcification front, which is basically like a transition zone between the osteoid seam that's being formed and the older mineralized bone. So bone deposit means that you're actively building the bone, courtesy of the osteoblast, and the formation, of course, will entail the format of the osteoid, which is the extracellular matrix, which will start to calcify and harden. Bone resorption is going to entail the breaking down of the bone, and that is going to be osteoclast. The osteoclast is very successful at this because it's able to secrete a lysosomal enzymes, and this creates an acidic mixture that basically starts to break down or dissolve, and it allows the calcification to go from a hardened to more of a soluble form, breaking down the entire compact bone, as well as some of the spongy bone in the particular location that is being resorbed. All right. I do want to tell you about how the osteoclast activity involves the parathyroid hormone. If you could just bear with me for 1 second, I'm going to show you that in actually an illustrated form, and that'll make a little bit more sense. The control of remodeling is basically continuous, and it's regulated by genetic factors as well as by hormonal control. So that's where your parathyroid hormone is going to come in just 5 seconds, as well as the response to mechanical stress. And that's referred to as Wolff's Law, which basically states that the bones will grow and form and remodel in response to the stress that's being placed on them. All right, so I mentioned the parathyroid hormone. So I wanted to show you this illustration right here because it's a good example of homeostasis at work. And what we see happening is that our body utilizes calcium for a wider range of things, obviously for bone format, bone health, muscle contraction, a wide array of things require calcium. So it is important to maintain a homeostatic level of calcium within the bloodstream. And what we see happening is that if there's anything that allows for the blood calcium levels to fall and become too low, that could be detrimental to the system. So what the body will do is it will go ahead and stimulate the parathyroid glands, which are located, here are these little yellow nodules. They are located behind the thyroid gland. The body will stimulate the parathyroid gland to start releasing PTH, or parathyroid hormone. And once again, this hormone is released as a result of falling blood levels of calcium. As the parathyroid hormone is released, it will go about fixing the issue and increasing the blood calcium levels. And the best way to do that is to get the calcium that is encased within the bones. So it will activate large amounts of osteoclast cells to break down bone. And as it's breaking down the bone, it's causing the calcium that was trapped in the matrix to be released, and that calcium will then go into the bloodstream, allowing the balance or the homeostatic levels of calcium to be restored. So this is one of the hormonal controls that we see happening for bone remodeling. And please keep in mind that the parathyroid hormone will be secreted anytime that there are low levels or falling levels of calcium in the bloodstream, and it will then respond by increasing those calcium levels by activating osteoclast cells, which will do so by breaking down the bone. And as the bone is reabsorbed or broken down, it will release the calcium that was being held into the extracellular matrix. All right, and here's Wolff's Law, an illustration of Wolff's Law, basically showing you that the bone formation will grow or form depending on the amount of tension and compression that's being placed on it. Now, as you can imagine, sometimes things don't go as we would like, so there might be some fractures or breaks that come into the bone. And this can be a combination of trauma, but it can also be an a clinical application where you might have weakness in the bone, perhaps because of osteoporosis. Osteoporosis is a really good example where we lose the balance of osteoblast versus osteoclast, so bone building and bone breaking cell. People with osteoporosis usually have very aggressive osteoclast, meaning that the bone has a really easy time being broken down, but it's not able to be built back up. So a lesser level or a lower activity of osteoblast activity. A bone density test is an excellent way to see the strength of osteoblast versus osteoclast. So that is one way that the initial stage of osteoporosis or the progression of the disease can be monitored. Now, the fractures can be classified different ways. It depends, for instance, if it is non-displaced versus displaced. Non-displaced means that even though you have a break, the bone is still within its original location. Displaced means that it has moved from that original location and it has to be reset before it can be properly healed. Complete versus incomplete. Complete would mean that you have a full break on where you have two or more separate pieces. Incomplete means that you have a partial break, so the bone is still intact, but it has a tear running through it. Open versus closed. Open means that the break has actually protruded through the muscle and the skin, and closed means that the break is still being held in internally, so it still has the layer of muscle and skin protecting it. Let me go ahead and show you a few locations and appearances, and this will kind of come into play. Now, these are just some of the most common types of fractures. So starting off with the commuted, we see that that happens when the bone fragment breaks into 3 or more pieces. This is usually seen when you have a patient who comes in with brittle bones. Then you have a compression. Now, the compression can be very painful because what happens is, and we also see this with porous bones, is that the bone will literally be crushed. So people with osteoporosis have to be very careful that this doesn't happen. And when it does happen, it's very painful because, as you can imagine, all the nerves that are running through there basically get compressed as well. It also has the ability to completely change the overall formation of the vertebra, allowing for a hunchback appearance to form. Excuse me. Over here we have a spiral fracture. The spiral fracture is usually the end of like a twisting force. This is actually the most common sports fracture that occurs, and as you can see, it does have a high and a low point because of the twist formation. If there is an issue with the epiphyseal plate, we call it an epiphyseal fracture, and that is because the fracture has occurred along the plate format. Usually that happens if there's some issue with the overall health of the cartilage cells. There will be some calcification that will occur within the matrix over there. Here is what they call a depressed fraction, and that basically means that you have a piece of broken bone that has collapsed inward. We usually see that within the skull. You can see it being highlighted. And then last but not least is the green stick fracture. This one is extremely common in children. The green stick is basically when you have an incomplete break within the bone. And then you can see that on one side, the shaft is broken, on the other side is still fully intact. However, it will create a bending motion, which is then detected whenever you go and you get an X-ray. Fraction does occur. There are different treatments options, but most of the time what we need to do is we need to make sure that you properly realign the bone, and if there is a close reduction, meaning that it doesn't come out of its original cavity, then the physician can often manipulate and then do a soft or a hard cast to keep it in place. If there's an open reduction, then that will entail a little bit more of work. My apologies, I couldn't think of the word, such as pins and wires to secure the end location to make sure that the bone can properly heal. The importance is, though, is that often immobilization is essential, and part of that is because, as we'll see in a little bit, as the bone starts to form, there will be a bony callus that is very sensitive, and any excessive motion can cause that callus to break apart, meaning that the whole process of repair has to start all over again. This is one of the reasons, of course, why your patients will receive a cast if a fracture is detected. So here are the 4 main stages of fracture treatment. You have your hematoma formation. This will involve an engulfing of excess blood supply in the area of injury. Then we're going to go ahead and start with our cartilage. So we're going to have our fibrocartilage callus that'll start to form, and then that will then be replaced by the bone. So you can see in step 3 and 4, you'll have your bony callus formation, and once it's formed, we do have to remodel it, so that can take a little bit longer at the tail end of the repair mechanism. Here, illustrated example of the healing of the bone fractures. So you could see, starting off with the hematoma format, this will ensure that there is lots of blood supply in the area of injury, allowing for all the various cells to come over and start to repair. And as we've talked about in this chapter, first we start with the cartilage, and then we transition with the bone. So you can see that the fibrocartilage callus starts to form. Notice how there is an increase in the blood supply as it's bringing over additional chondrocytes. And of course, eventually your osteoblasts will be introduced as well. We can see the formation of the trabecula start to form. And as the cartilage is replaced by bone, we see that now we go and form a bony callus. Bony callus, you can see right here being highlighted within the spongy bone area, and then eventually this section right here that has spongy bone will eventually be replaced by compact bone. Now, once that happens, you might notice that there are some little bumps and grooves along the sides of the bone, and part of those are areas of calcification. So what bone remodeling entails is that it starts breaking down and repairing these areas of irregularities, and this can take a few months, if not a few years, but keeping in mind at that point the patient is already out of the cast and they're just monitoring to make sure that everything is going fine. It is important for immobilization to occur between step 1 and 3. And part of that, of course, is because that will assist with the aid with the repair of the fracture. All right, having said that, I think that this is our end of our chapter. If at any time you have any questions, comments, or concern, remember that I am an email away, and we will obviously, or I will say we will hopefully go ahead and reunite for our next chapter. All right, everyone, go and enjoy the rest of your day. Talk soon. Bye.